All right, I have two cases for you on this video. 71-year-old male with chest pain and a 37-year-old male with chest pain. This is a Monroe link. One case comes from Dr. Jeffrey Traeger. The other comes from Ryan Hartle. This is Dr. Traeger. He's a good dude. We worked together for years at Monroe before they closed it down. He knows a lot of stuff. This is Dr. Hartle. You probably know him. Graduated from Monroe a couple of years ago. Anything he has taught you or told you, I told him first. So I'm expecting my royalty check soon, for Christmas at least. All right, here we go. Case 1, chest pain, mid-sternal, radiates to left arm, 7 out of 10 pain, no cardiac history, 34-year-old with past medical history of diabetes, presenting with complaint of chest pain since 8:30 a.m. Patient reports his pain started when he was at work. He never had this before and doesn't see a cardiologist. He reports the pain is non-radiating and constant. Nothing makes the pain worse or better. He didn't take any medications this morning. He reports associated numbness in his left arm. He rates his pain a 7 out of 10 and describes it as a cramp. Denies any shortness of breath, fever, cough, nausea, vomiting, diarrhea, or diaphoresis. All right. So the value of the EKG depends on your pretest probability. The pretest probability overall here, I would say, is maybe moderate, medium. He's young. He's 34. His only history is diabetes. The pain he's describing is not classic. But again, he's a diabetic, and diabetics present with atypical signs and symptoms. It does radiate to his arm, but he denies shortness of breath or diaphoresis. So I'd say overall moderate. So here's the EKG Dr. Hartle had. Pause, write down your findings, and think about what your interpretation is. All right, so here's EKG number 1 at 11:46, and there's nothing old to compare to. So let's just go through it together. Number 1 down here for the rhythm strip, which is always either lead 2 or V2. What we're looking for is there 1P for every QRS. There is down here, so we're sinus, and we can move on. We're done with that. The rate overall is normal. If we do look down here in the rhythm strip, there is maybe some abnormal appearance of the P wave. Maybe it's notched or kind of high. If we look up here, maybe a little bit of left atrial enlargement, but again, nothing crazy and or pathologic. For the rate, I'd say overall it's normal. For the access, it's up in 1 and up in AVF, so I would say normal. For the intervals, I do not see any widening of the QRS or prolongation of the QTC, so I'd say that's normal. So let's move on to ST waves. So if we look closely, there are multiple ST wave abnormalities. The first one, I hope draws your eye, is this inversion in AVL. Okay, number 1, the ST segment is below the isoelectric point. And number 2, look how linear it is. Okay. The linearity of this ST segment, if we extrapolate it out, is almost greater than the amplitude of the QRS. That's highly concerning. For me, I always reference AVL because for me, AVL is the most sensitive finding for an occlusion in the coronary arteries. The reason I think that is because of physics. Okay, all this EKG is doing is we're measuring vectors that are passing through a medium, which is the myocardium. If you think about it, the overall vector of the heart is from top right to bottom left, which most closely follows AVL. My contention is that if you have a problem with one part of the heart causing a change in the myocardium at that area, it's going to cause a repolarization abnormality in AVL regardless of what the area is. Whether it's the anterior portion, the left, the right, the posterior, whichever one's being affected, I think AVL is most likely to have a repolarization abnormality because of that vector principle. Again, that's all just stuff I believe. If you like it, great. If not, I don't care. Other repolarization abnormalities we have here is in V2. We do have slight J-point depression. There's the PR segment right there. There's the J-point. I'd say maybe 0.5 millimeter of depression. Again, we have linearity of the ST segment here. A little bit of J-point deviation here in V3. We do have some over here in V4, V5, and V6. And we do see, what looks almost like a Spodek sign or a downsloping of the isoelectric point over here, which is, again, nonspecific, most often seen in pericarditis, but focally it can be concerning for coronary artery disease. And we also have repolarization abnormalities over here in 2-3 and AVF. Okay, so if we look closely, there is some J-point deviation. Here in lead 2, here's the PR segment. There's the J-point, maybe a 0.5 millimeter. Same thing down here in lead 3. There is the PR segment, there's the J-point. Same issue here in AVF. There's the PR segment, there's the J-point. And again, note the linearity of the ST segments. Like looking here in AVF, that's very linear. Here in lead 3, it's very linear as well. And same issue over here in lead 3, linear as well. And again, for these leads, if we extrapolate out that, compared it to the amplitude of the QRS, it's definitely over half the size. Also, I just noticed there is signs of a fractionated QRS here in 2-3 and AVF. If you notice, there is a slight slurring of the QRS in this down segment here. You can see it there in AVF, there in 3, there in 2. That's a fractionated QRS. Every time you see that, think about structural heart disease. This particular appearance can be associated with what's called a reverse delta sign, which can be associated with mitral valve prolapse. So overall, my interpretation is this is a non-specific EKG. There may be some signs of ischemia, but no definitive signs of infarction or arrhythmia. So Dr. Hartle, with all of his knowledge, was concerned with his AVL inversion. So he works him up. He gets a repeat EKG a little while longer. And again, if we look at this, we see these same abnormalities. Number 1, AVL, okay? Like, not only do we have this J-point depression here, but also look at this linearity of this segment here. And it's definitely below the isoelectric point, right? Now we do have some J-point deviation here in AVF. There's the PR segment. There's the J-point. Same issue here in lead 3. There's the PR segment. There's a J-point. And again, same issue here in lead 2. There's the PR segment. There's the J-point. This EKG also is another example of why, in my opinion, you should always use the PR segment when you're looking at the J-point if you're ever concerned about infarction or ischemia. I mean, because if we look down here in lead AVF, okay, here's the end of the T segment, here's the beginning of the P segment, and here's the J-point. I mean, those are all pretty much on the same line. Like, there is no J-point deviation when you compare it to the TP segment. But when you do compare it to the PR segment, there is signs of J-point deviation. So that's why I always recommend you use the PR segment. And again, over here in the lateral leads, you can see in V6 as well. Same issue, we have this J-point deviation. Same thing over here in V5 as well. Is this overall interpretation, is this an infarct? Same thing. Not necessarily. There's not enough to qualify based on the recommendations as we talked about before. But Dr. Hartle says, pish posh, I know more than that. He was highly concerned. Dr. Traeger talked to cardiology. He says, yeah, no, this is not a STEMI, but he needs to go to the cath lab. The cardiologist took him, and here's what it shows. Severe occlusion of the proximal LAD. Okay. Again, was this a STEMI? Not necessarily, but with the symptoms, the focal repolarization abnormalities, specifically the inversion in AVL, that's what tipped off Dr. Traeger to be aggressive and repeat the EKG and get cardiology involved early. And this is a good outcome in this case. I mean, this is a young guy. Like, Dr. Traeger saved him like a lot of problems by identifying this early. I mean, think about how much of his heart muscle he saved. Here is Hartle's case. 71-year-old male presents to the ED for complaints of chest pain. Paints reports symptoms has been present for the past 2 days. Reports the pain is 8 out of 10 at this time. The patient and son who is present at the bedside report patient has no significant medical history. Does not follow up with a primary care provider. Okay. Patient denies any dizziness, lightheadedness, or headache. Patient denies any swelling to his lower extremities. Denies any cough, fever, or chills. Patient denies any nausea or vomiting, denies any appetite changes. He denies any urinary symptoms, constipation, or diarrhea. So overall, for the pretest probability, again, this is medium. I don't have much to go on. Like, again, he reports no past medical history. That doesn't mean he doesn't have any. It just means he doesn't report any. So overall, I'd say it's moderate pretest probability. Here's the EKG Dr. Hartle has. Again, there's nothing old to compare to. I recommend you pause, write down your findings, and think about what your interpretation is. All right, so here's what I see. We do have a sinus rhythm, and when we look down here at the rhythm strip, we do have 1p for every QRS. The interval is kind of irregular, but again, there's 1p for every QRS. Is it normal sinus? Not necessarily, but it is a sinus rhythm in my opinion. In my opinion, I would qualify this as a wandering atrial pacemaker or an ectopic atrial pacemaker because we have two different P-wave morphologies at two different PR intervals. Like this one is kind of broad and this one is more peaked. Remember, the difference between wandering atrial pacemaker and multifocal atrial tachycardia is twofold. Number one, the rate. In order to be MAT, you have to be tachycardic, obviously. Number two, for MAT, you have to have more than two different P-wave morphologies. Again, for me, this is an atrial rhythm, a sinus rhythm. It's most likely due to underlying lung pathology, but is it important and crazy? No, not necessarily. The axis, I would say, is left because it's up in 1 and down in AVF. I do see that we have borderline signs of LVH because this QRS amplitude in AVL is approaching over 10 millimeters. The intervals, I'd say, is normal. I don't see any prolongation of the QTC or QRS intervals. The main issue here is the ST segments. Now, diffusely, I see many abnormalities. The first one I hope that draws your eye is AVL. Again, we have slight depression and inversion and linearity of the segment in AVL. We have nothing old to compare to, so we can't confirm if that's new. But again, in the setting of acute coronary syndrome, inversion and or depression in AVL should always be a huge red flag. We have that same repolarization abnormality over here in lead 1. There's the PR segment. There's the J point, maybe 1 millimeter of depression. And again, some linearity of this ST segment. Same issue here, linearity and repolarization abnormalities. Same issue here. In V2, we do have some J-point depression from the PR segment. We also have a slight depression here, maybe 0.5 millimeter, but nothing to qualify for an infarct. We have the same issues over here in the lateral leads. You can see it, especially pretty good in V6. Here's the PR segment. There's the J-point, maybe 1.5 to 2 millimeters depression, and again, linear to the ST segment. Same issue here in V5. Okay. And again, we have, it's pretty close, but it looks like we might have a T-wave in V1 bigger than V6. Again, all of these things don't qualify for an infarct. They're all non-specific signs, but in the settings of acute coronary syndrome, they should be highly concerning. And Dr. Hartle is nobody's fool. So again, just like Dr. Traeger, he was highly concerned. He got aggressive with his patient. Ordered all of his labs, ordered meds, and ordered a repeat EKG. Here's his EKG at 9:30. Again, we have the same repolarization abnormalities that don't qualify for an infarct. Number one, in AVL, we have this depression, this inversion, and this linearity. Same issues as before up here in lead 1. Same non-specific issues in 2 and 3. Looks like V2 and V3 maybe got a little bit better. I don't see as much J-point deviation here, and the linearity got better. V6 and V5 definitely improved somewhat. And again, we do have this V1 that's larger than V6. Okay. Again, is this an infarct? No, but all non-specific findings and highly concerning, especially if he has active symptoms, which he did. So Dr. Hartle got cardiology involved, says, hey, I think this patient needs to go to the cath lab. They say, no, but it's not a STEMI, he can wait. Dr. Hartle gets a 30 EKG, which again shows the same non-specific repolarization abnormalities, but they've improved here. Like, look, like AVL has improved. I mean, it's still depressed and it's still linear compared to the amplitude of the QRS. Same thing here. And lead 1 got improved. Same thing here, but a little bit better. Same thing over here. This is like much improved. And same thing over here, like this T-wave amplitude from V1 to V6 improved. So those are all reassuring signs. And the most reassuring thing, which I didn't get to talk to Hartle about, was what did his symptoms improved. But regardless, Hartle was like, I think this guy needs a heart cath. They're like, no, we'll see what happens. So he gets admitted, and here's what happens with the troponins: mildly elevated in the emergency room, and then get higher and higher. And of course, he goes to the cath lab, and he has multivessel coronary disease. And he gets a stent in his LAD and his obtuse marginal. You can see the stenosis and the problems over here. Like, look at this. Ooh, look at that stenosis there. Ew, that's ugly. I mean, he's got some mild disease here as well. Look at, there's some disease up here as well, too. Ooh, same thing here. This is an ugly guy. Look at all that lack of flow. What does the literature tell us? So both of these cases, which tipped off our astute physicians, was inversion in AVL. As I said before, for me, anytime I'm worried about acute coronary syndrome, if I see inversion or depression AVL, especially which is new, a huge red flag goes up. I'm very aggressive. I order all the labs, I order the medications, the morphine, the aspirin, the nitro, and I'm always repeating EKGs at least 15, 20 minutes and seeing how their symptoms are improving. Now here's what the literature says, and again, you can read this at your leisure and look it up on the website. This inversion is not very specific, like you can't hang your hat on it, but again, for me, it's a huge red flag that should tip you off as how aggressive you'd be for a patient. Here's a case report from online, and again, look at this EKG. This patient comes in. Is this a STEMI? No, but look what we have here. I mean, we have this inversion here in linearity. In AVL compared to, look at this. This whole ST segment is greater than the amplitude of the QRS. And we have similar issues here as well. Also, they don't note it, but look down here in lead 3, like look at this hyperacute T wave. Like this entire QRS can fit underneath that T wave. We also have, V1 maybe slightly bigger than a V6. Okay, and again, are these things a STEMI? No, but these repolarization abnormalities, especially in the proper clinical setting, should set off a huge red flag and definitely affect your management of the patient in the emergency room. Same online case I found. Ooh, this is a nice EKG. Again, like number 1, look at AVL. Like look at this inversion, and again, look at this linearity segment. It's greater than the amplitude of the QRS. Same thing here. Look at this linearity outside of the QRS. Ooh, same issues. Like look at here in lead 3. Not only do we have, J-point deviation, but look, this entire QRS can fit underneath that T wave. And again here, look at the amplitude of this T wave compared to the amplitude of the QRS. Definitely hyperacute. And again, we don't really have it, but we have a T wave in V1. Nah, it's not bigger than V6. Same patient a little while longer. Now you can definitely see this is an infarct. Number 1, look, this inversion in AVL has gotten worse. It's worse in lead 1. And now we have J-point or ST elevation in these 2 leads. Again, the main point for this one is the inversion in AVL. More literature. This one says isolated T-wave inversion in AVL had a high specificity. You can read this paper at your leisure if you want. Here's all their mathematics. Same thing, was it a sufficiently powered study? Not necessarily. Again, just a non-specific finding. Same thing with this EKG or this study. They wanted to highlight the importance of people not knowing about T-wave inversion. Like, is it, this person has to go to the cath lab right away? No, but it's something that definitely should raise your awareness and affect how you're treating this patient in the emergency room. So that's all I have for this video. Short of the story is T-wave inversion in AVL. If it's new and you have the proper pretest probability, like symptoms, risk factors, it should set off a huge red flag and should make you be very aggressive for this patient. Order them the proper medications, repeat and reevaluate that patient oftenly. What you're looking for is their dynamic changes on the EKG and can not control their symptoms. All right, that's all I have for this case. I hope you enjoyed it. Any questions, ask me in person. Peace, I'm out of here.